now. So you might see that little consent statement. Crystal Morris from City of Hope put in Dr. Schultz Costello's information in the chat. Feel free to submit your questions by the chat, and they may be answered throughout the.
Oh dear.
We lost you, Allie. You're on mute.
Oh, can everyone hear me?
Yep.
Okay, was I on mute the whole time or just the end?
No,
Just a little bit.
Okay. Okay, it said the host muted me, so I don't know what happened. This will be recorded. Submit questions in the chat and they can be answered throughout or at the end. Just a brief introduction. Dr. Catherine Schultz Costello, born in Southern California, has been really active in the medical community. She earned her degree at Western University of Health Sciences, the College of Osteopathic Medicine of the Pacific in Pomona. She did her residency at Arrowhead Regional Medical Center in Colton, and she did her breast cancer surgery fellowship at City of Hope, where she now is. So thank you so much for being here. We are recording. I'm going to go ahead and step aside here and let you take it away, but feel free to let me know if there's anything you need.
Okay, awesome. Thank you guys so much for joining. I'm very passionate about talking about breast cancer. And so any questions you have, you can either type them in the message as we go, or if you want to like speak up and talk, whatever we need, we can keep it very, very casual. So I want to go over some things about prevention and screening for breast cancer. Many of you may have been affected by breast cancer, either personally or by a loved one. And so we can talk about first, this is just going to be an overview of how common breast cancer is, things we can do to modify risk of breast cancer, screening test, and breast cancer is very common. So it's about 1 in 8 women. It's the most common type of cancer in women. Skin cancer is technically the most common, but beyond skin cancer, non-melanoma type skin cancers, breast cancer is the most common. It is not the most common cause of cancer death. Lung cancer is the leading cause of death, and so breast cancer is only second. The incidence has only gone up a little bit the last few years, even though it sometimes feels like to me, it seems like it's, exponentially going up every week. And there's a lot of breast cancer survivors. So most women, when they get diagnosed with breast cancer, they're more likely to, survive it as opposed to some other cancers, which aren't as curable and treatable. There's a lot of different things I'm going to talk about that are things that we can change to help reduce the risk of breast cancer. So modifiable risk factors are things that you can change. For example, like quitting smoking can decrease your risk of lung cancer. And then there's certain things that you really can't change. Like you can't change how old you are. We can't change that we're female, and so we're higher risk to get breast cancer. And so this is an example of some of the things we can't change. Age, gender, race. Of note, African Americans have an increased risk of triple negative breast cancer, which we talked about a little bit, are harder to treat. Genetics, if you were born with a gene that predisposed you to get breast cancer, you can't change that. If you've had breast cancer, your family members have had breast cancer, you can't change that. Breast density is a really interesting one. For whatever reason, some women have more dense breast, and that makes screening a little bit more difficult. And we'll go over that at the very end about the screening, but probably also increases the risk of breast cancer. We'll talk about a little bit about periods and late menopause, and then if you've had a history of atypia or any sort of proliferative breast diseases. Age is one of the most important risk factors. So the older we get, actually the risk of breast cancer goes up until about 75, and then the risk of breast cancer goes down. I still see patients in their 80s and 90s with breast cancer, but certainly the highest risk group is probably, you can see about this 50 to maybe 75 risk. We talked about some of these, and a lot of these in terms of periods and late menopause and things like that all have to do with how many periods you have in your life, even though that might sound a little bit funny. I use the analogy that like every time you have a period, there's changes in your breast. So your breast undergo changes, your ovaries undergo changes, because every time you have a period, your body's preparing for a pregnancy. So you're having a surge of hormones. And then if you don't get pregnant, there's a change in hormones. And every time you have change in the body, there's a chance for a mutation to occur. And the more mutations that happen, the higher risk to get a cancer. And the less periods that you have in your life, the less mutations you have. So if somebody got their first period when they were like 7, I'm just going to say really young, and they got their last period when they were 60, and they never had any babies, that person is higher risk to get breast cancer than somebody who got their first period at 15, had 6 pregnancies, and went into menopause at 45. So that second person had a lot less changes in her life. And so less opportunity for mutations, less risk of getting cancer. Now this is not perfect. Obviously, if somebody, I see women all the time. I just saw somebody this week who had 6 daughters, and she breastfed like 2 years for each child. And, she still got breast cancer. And so it's like, sometimes it doesn't make sense. And so I use the analogy of like getting in a car accident. If you never drive, you will never get in a car accident. But the more you drive, the more periods you have, the higher risk of something happening. Some of the risk factors you can change for breast cancer is your weight, lack of physical activity, alcohol use, hormone replacement. I'm not saying anybody needs to get pregnant or to breastfeed, but those things do decrease the risk of breast cancer. So they're considered modifiable risk factors. A lot of women are overweight or obese. The most frequently used assessment is body mass index. And this has limitations in certain populations and also for women that are, just built different frames. But it is true that the more you weigh, the more at risk you are for breast cancer. And the reason that is a lot of cancers feed off estrogen, and fat in the body makes estrogen. So the more fat cells you have in the body, the more promotion of these hormone-driven breast cancers, which are like more than 70% of breast cancers. In addition, we think that probably having excess body fat also creates some level of inflammation in the body, and that can increase the risk of breast cancer, can also increase the risk of recurrence. There's also probably something having to do with insulin in the body. Sometimes when anybody gains weight and you have a lot of fat in the body, you develop what's called insulin resistance, where your body just doesn't recognize insulin as much. It's kind of gotten a little bit like immune to it. And so they also think that has to do with probably a role in developing breast cancer. And it probably has something to do with hormones also as well. But good news is people can lose weight, and that can lower their breast cancer risk. They've seen that in a lot of studies that weight loss after menopause actually reduces the risk of breast cancer. What's interesting is this isn't actually true for young women that get breast cancer. Young women that are overweight actually have a lower risk of getting breast cancer than women who are thinner before menopause. And then it switches after menopause, where the excess weight actually does increase the risk of breast cancer. And so, there's been a lot of studies that have shown like the more weight you lose, the lower the breast cancer risk. So weight loss is one great way to reduce the risk of breast cancer if you haven't had breast cancer, or to help decrease the chance of a recurrence. Exercise is also a wonderful way to reduce the risk of breast cancer. There's been studies that have shown numbers between 12 to 21%. It works for both premenopausal and postmenopausal women. We really don't know why it reduces the risk of breast cancer, but probably has to do with what we just talked about, how when you have excess fat in the body, that increases the amount of estrogen in our body. And so that physical exercise reduces that, and then reduces the risk of getting breast cancer. How much exercise do you need? There's studies that say 2.5 to 5 hours a day. And some of that does have to be more aerobic activity, where you get your heart rate up, meaning that simply, like walking a mile or walking 2 miles every single day probably doesn't have the same effect as if you like ran really hard twice a week or did something where your heart rate gets up really well. I'm also a big fan of encouraging patients to do some sort of strength training. I think that there's a tendency not to lose weights and try to do really like low impact training. But if you can do something that helps with strengthening and actually like building muscle, not only does that help burn calories and lose weight, but it's also really great for your bone health. A lot of women that have been undergone breast cancer treatment will have issues with bones health. And so walking and things like that actually don't help with that. But strength training, weight training does. And the next slide just talks about in breast cancer survivors that all of any sort of exercise actually can help with anxiety, depression, fatigue, improve quality of life. It is safe for everybody. Sometimes women are afraid of lymphedema risk with exercise, but it's completely fine. Great for bone health. And again, it decreases the risk of death from any cause. Even though we talked about on the first slide that breast cancer is the most common cancer in women, and then we talked about lung cancer is actually the most common cause of cancer-related death, still the number one cause of death in women is heart disease. And I think it's something that a lot of people don't talk about at all, but everything that is good for reducing your risk of breast cancer is also really good for reducing your risk of heart disease. So exercise and healthy diet, all these things are really good. Also on this slide is a mention about colorectal cancer. And I'm going to talk about it one more time at the end too, but if nobody has had a colonoscopy, with breast cancer, we have mammograms. Colon cancer is the number 3 most common cancer in women and the number 3 most common cause of cancer death. So if you or your husband or a partner or a friend, if anybody has not had a colonoscopy, I encourage them to get colonoscopies. They changed the screening age to age 45 because the onset of colon cancer is getting younger and younger. Alcohol is another thing that people can modify. There's a strong evidence that alcohol leads to multiple cancers, including breast cancer. And women that drink more than 1 drink a day have an increased risk of breast cancer. And we can see this in countries where they drink a lot more than like Americans do. So in Italy, they drink wine a lot more, and they can actually attribute probably 7% of breast cancers potentially from the increased amount of alcohol use. I also tell women though, you have to like enjoy your life. So if you really enjoy having a glass of wine or having beer or some other sort of drink, that is completely fine. That is completely safe, but you should not be drinking every single day. Hormone replacement therapy is something else that we can help decrease our risk of breast cancer. There was the Women's Health Initiative study that took place in the early 2000s that showed if women used hormones that there was an increased risk of breast cancer. Combination hormone replacement actually increases the risk the most, and estrogen only, you actually have to use it for a longer period of time to actually see an increased risk of breast cancer. There's things called bioidentical hormones, and there are synthetic hormones that are identical to the hormones your body produces. There's also natural hormones that are derived from plants. A lot of these, there's a whole world of like hormone replacement therapy. We really don't know how much these increase the risk of breast cancer. And so I'm not sure. And there hasn't been any randomized trials yet that have reviewed that. Sometimes women ask me if they've had breast cancer or maybe they're taking birth control, or, they want to know for their daughters, is it okay to be taking birth control? Birth control is most commonly estrogen and progesterone. So it's a combination type of hormone therapy. And it probably does increase the breast cancer risk, but it's such a small amount that it's it's really safe to take. And so I don't recommend people not to take birth control, even if they have a family history. Just like we talked about, the more babies somebody has, the more protective the pregnancy is against getting breast cancer. And it's just really because of all the hormone changes that happens with these things that we have less amount of menstrual periods, and that decreases the breast cancer risk. Same thing with breastfeeding, that lowers the breast cancer risk because of the less menstrual cycles. Also, there's potentially a tendency for women who breastfeed to eat and live healthier and to limit alcohol and smoking use when they breastfeed. So to summarize some of this, maintaining a healthy weight is really important to decrease the breast cancer risk. Be physically active with a target of like 2.5 hours to 5 hours per week. I don't think most people, it's healthy to exercise every single day. And I think that people burn out. You could just start very gradually with like 15 minutes of walking and then build up to, more of jogging or running or low impact things like bicycling. And I know like the Peloton bikes are so popular now, swimming, hiking, doing things, but you need to feel your heart rate get up. Limit, alcohol. Eat a healthful diet. And I wish I could go into this more because I do think that this has a huge link to breast cancers and all cancers in general. So limiting fast foods, the more whole grains you eat, the more fruits and vegetables, and limiting red and processed meats. Don't be drinking, a lot of like sugar calories, like regular Cokes and things like that. I even think that there's probably going to be, a proven cancer link to things like diet drinks, just things that are not natural. Try to limit them. There's no real supplements for cancer prevention I can recommend. It's better to get your vitamins and minerals from your daily diet. And then, of course, avoiding smoking in terms of breast cancer risk. There are some women that are high risk to get breast cancer, and they want to do more to decrease that cancer risk. And there are medications that can do that. They're the same medications that a lot of women that get breast cancer are actually put on. And the most common one is called Tamoxifen. These are medications that block estrogen in the body. And they reduce the risk of breast cancer for some women. I mean, it can be like a 50 to 80% reduction in risk of breast cancer. So they're very powerful medicines. They do have side effects. So a lot of women, even that have had breast cancer, have trouble staying on them. Tamoxifen's most common side effects is hot flashes. It has a few more serious side effects, like it can increase the risk of blood clots. It can also increase the risk of uterine cancer. And you do need to be on it for 2 to 5 years to actually see the benefit. I don't really recommend beyond 5 years if it's just being used for primary chemo prevention. I think there's a huge, 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 huge role that stress has in developing cancers and probably other diseases too in the body, even heart disease. I don't think that anyone's been able to make a true, scientific link. And I think it's something that's also really hard to prove. But I do encourage patients to try to figure out ways to cope with stress in their life and with anxiety and everything that happens to us in life in as healthy as a way as possible, to not internalize and not have our bodies hang on to that stress. If you have, a stressful job that's eating you up, if you're, just anything in our lives that you're able to deal with that. I'm a huge fan of meditation and other things that we can do to reduce the stress. Exercise is also really good for stress relief. A lot of women can correlate the diagnosis of their breast cancer with a stressful time in their life. And so I just think that stress is really important for cancer risk. Something that's becoming a little bit more talked about, definitely in the media and in scientific journals, are endocrine disrupting chemicals called EDC. And these are chemicals that we are being exposed to that either mimic or disrupt the action of natural hormones. And there's a lot of different ways that we may have gotten exposed to them. And there's a lot of people that think that, you're exposed when you're in your mom's tummy. So it's like long, long before you were born. And we know that from studies with DES that showed the double risk of breast cancer in women's daughters, and DDT exposure, almost a 4-fold increased breast cancer risk. There was a study in the last 2 years that was also went across the media that showed hair dyes and straighteners were actually associated with an increased risk of breast cancer. This study, unfortunately, needs to be taken with a little bit of grain of salt. It was looking at women whose sisters had breast cancer. So we don't know if they were higher risk from that respect. But something just to keep in mind, I think hair dye is safe. My mom had breast cancer. She dyes her hair. I wouldn't tell her to like stop dyeing her hair, but it's just something to be aware of. Exposure to plastics also is becoming a little bit more talked about. We are definitely ingesting way too much plastic where all of our food is packaged in it. We're drinking out of bottled water all the time. Try to limit your use of plastics, like stainless steel cups instead of using plastic water bottles. I have one of mine here. Do not heat up food in plastic. So microwaving in plastics is a really, way that plastics can get into our food. I think also limiting certain types of products that you put on your skin too that can contain plastics. This summer, I recommended to all my patients not to use chemical sunscreens. For sure, benzenes are getting into our body, which are also endocrine disruptors. Only use mineral-based sunscreen. Unfortunately, these are the ones that appear a little bit more white on the skin, by titanium dioxide and zinc oxide. Otherwise, using sun protection clothing, so you're not even, being exposed to any chemicals. They've come out with a lot of different things that help cover your whole body, like a lot of different new hats and like shirts. My cousin went to the Bora Bora this summer and she like wore like a full almost like wetsuit type thing just to protect against the sun exposure and not having to, apply a lot of sunscreen. Washing fruits and vegetables really is important. You can reduce the amount of pesticides that you're consuming by peeling produce or by soaking in baking soda and water mixture for 15 minutes. I do think that there's certain fruits and vegetables that are better to get organic, even though there is a cost difference. And there's a list that's released every year. I think it's called the Dirty Dozen, and it goes over certain fruits and vegetables that, they think are better this year to definitely buy organic. A lot of it has to do with ones that you're consuming the skin on. So like berries, like a strawberry, for example, versus, like a banana, probably better to get organic strawberries. And then there hasn't really been any connection with seafood and breast cancer, but I did want to bring it up because a lot of the seafood also has endocrine disruptors in it, depending where it's from. One article I was reading to prepare for this talk was talking about coastal Europe, that it's highly contaminated. So just be aware where your food is coming from and, things that can be lurking in it, unfortunately. And this is a little diagram from a paper that was published in 2014 about the endocrine disruption and maybe how this is increasing breast cancer. So all of these things in the blue side are potentially endocrine disruptors. And on the other side in the green is risk factors. So high fat diet, never having babies, how old you were when you got your first period, how old you were when you went into menopause, and early life endocrine disruptor chemical exposure, and how all of these things have to, cause DNA damage and genetic changes and things like that, that can increase the risk of breast cancer. So I think this is real. And I don't mean any of this to like scare us and we're all not gonna, enjoy our lives and enjoy favorite foods. I mean, I try to eat as much fruit and vegetables as I can. But I certainly don't not enjoy certain things. Next, we're going to shift the talk to screening. So screening is any sort of test that we do as a preventative measure. It's something where, we're trying to screen for something and find it in people that don't have any signs or symptoms. And the major goal with it is to find cancer early. So before it's spread, before it's even gone to the lymph nodes on that. Mammograms are our gold standard for screening for breast cancer. They are an X-ray of the breast, so it takes a picture in 2 different views. Most of the time it's performed every single year, but there's some societies that run it every 2 years. It's covered by insurance. It's the best test we have to detect an early stage breast cancer. We also use it as the primary gold standard to follow women that have had breast cancer. If anyone's ever wondered if they've ever seen on the report if it's a screening or a diagnostic mammogram, a screening mammogram is somebody that has no symptoms. So it's just somebody that's getting their annual mammogram, but they don't have any complaints. A diagnostic mammogram means that you have something going on, like you have pain, you may feel a lump, nipple discharge, a skin change. Typically, for the first few years after someone's diagnosed with breast cancer, we'll also do a diagnostic mammogram. And the difference on the medical side of it is a diagnostic mammogram has to be read by the radiologist while you're there. So if there's any areas that look a little bit suspicious, the radiologist will look at your mammogram before you leave. So sometimes you're waiting in the waiting room for a little bit of time and you're worried, but they may just be reading it and everything's fine. Or they're reading it and they want to take some more pictures. So before you go home, they have that opportunity to go in and often they do compression views. So if there's an area in your mammogram that just didn't look perfect, they just squeeze the breast a little bit more to see if there's something really there, or if it was just breast tissue overlapping, or sometimes take some better pictures of calcium spots on the breast. A lot of women have calcium spots in their breast, but cancer can also make calcium spots in the breast. So sometimes they want to take more pictures to see how suspicious they are. And so they'll do some zoomed in view. So those are the two different types of mammograms that your doctor may order. Some of the myths about mammograms: a mammogram exposes you to radiation, and so then that radiation is going to give you cancer. Mammograms do use radiation, but it's a really small dose. The dose is really small. Like we get exposed to more radiation a year just living on the planet Earth. And so it's nothing that is concerning to me. I would rather find a breast cancer early that is more treatable and limits the amount of cancer therapy that a patient has to go through than, have the radiation exposure. There's another type of mammogram that you may have heard of, and it's called 3D mammograms, or some places call it tomosynthesis. Those do have a little bit higher dose of radiation. So if you're concerned about radiation, you might want to get a more traditional mammogram. I love 3D mammograms. The way they work is instead of just taking the two pictures of the breast in each way, the mammogram machine actually takes little slices of the breast. And so the radiologist, instead of just looking again at one picture this way and this way, they can look at the breast in slices. And there's been some studies that have shown, especially in women 40 to 49 with dense breasts, that it increases the rate of early stage breast cancer detection. And then it decreases the callback rate. And what a callback is when someone goes in for their screening mammogram and they get this horrible phone call that they have to come back to take more pictures. And then they go back and there's nothing there. It just happens to be, dense breast tissue or overlapping breast tissue. But with the 3D mammogram, they're able to scan and see that right then and there. So there's not that, call back and then taking more pictures. A screening mammogram is guaranteed to find any type of breast cancer. I wish this was true. Some breast cancers are missed on mammogram, and a lot of that has to do with dense breast tissue. Dense breast tissue is just breast tissue that is still, I would say it's still young. The breasts are made up of milk glands and milk ducts, and then this fibrous tissue that kind of holds it together. That tissue appears white on a mammogram. And as we get older, that dense tissue, the milk glands, the milk ducts, the fibrous tissue, it goes away and is gradually replaced by fat. Does not happen for every single female, and sometimes it happens really young. But unfortunately, cancer also looks white. So if somebody has dense breast, it looks, their mammogram's mostly white, and then the radiologist is also looking for a cancer that is white. And so sadly, it can be missed. It's also one of the reasons why we don't do mammograms on women younger than 40 routinely. And it's because their breast tissue is just so dense that the mammogram wouldn't even be that sensitive. So we would be doing just so many mammograms and not even finding more cancers. There's two other types of tests that we can use to screen for breast cancer. One is ultrasound and the other one is MRI. Ultrasounds are great for looking in dense breast tissue. So a lot of you, if you've ever gotten a mammogram, and you'll get a report in the mail that says it was normal, but it's notifying that you have breast dense tissue. That was a law that was passed in California, so women are aware of it. And you can decide with your doctor if you should get an ultrasound to screen for breast cancer, which is a great adjunct. Not everybody needs one, but it's something that's there that can also help with dense tissue. MRI is a wonderful test. It's very, very sensitive. The downsides of it is that it is expensive and it has a higher false positive rate. And so we typically use it for women who are high risk for breast cancer or have already been diagnosed with breast cancer to basically map out their cancer. And if you guys have any questions about MRIs, we can talk about it more at the end. You can't get screened if you don't have breast implants. Breast implants are safe. There's no increased risk for breast cancer with silicone or saline, but women with implants should have regular mammograms, and they do have to do a little bit of extra pictures to kind of do ones with the mammogram in view, with the implant in view, and then also ones with the implant out of view. And then you just let your tech know that you have implants. They typically do have you sign a form saying that, something can happen to the implant with it. I've thankfully never actually seen an injury happen to an implant from a mammogram, but I'm sure it has happened. For screening mammograms, the benefit is really this reduction in mortality. There's a reduction in breast cancer deaths. There's life year gain. If we find an early stage breast cancer, you're, don't need as much surgery and you're less likely to need chemotherapy and radiation. The risks of getting a mammogram is, yes, you may have to go back and take more pictures. There are some women that have, a need for biopsies and it turns out to be okay. And the more you screen, the more you'll see that happen. And then of course, it's anxiety producing to have a test and worry about the results. And the mammograms can also be really uncomfortable for some women. Had some women who have gotten bruised from mammograms, or they have pain for honestly like 2 to 4 weeks afterwards, just because the amount of compression caused a little bit of trauma to their breast. I do recommend women are familiar with their breast. I think many of you may remember they used to really encourage self breast exams, and they would give tons of things for people in their showers and things like that. They've kind of moved away from that because so many women were feeling lumps and bumps and it was causing a lot of anxiety. But I still advocate, especially for my women that have had breast cancer, and a lot of women still find their breast cancers on their own, just to be familiar with your breast so that if something changes, that wasn't there before. And I think it's really important for women to look at their breast in the mirror and do different positions. So like bringing your arms up, putting them on your side. There's sometimes a few breast cancers that are found just because somebody notices like a dimple in their skin or their nipple looks a little bit different and you're comparing to the other side. A clinical breast exam is important once a year by your primary care or your gynecologist. Breast imaging with screening mammogram, and then MRI in select cases, and also a consideration for an ultrasound for some women. There's a few different guidelines on screening, so I'll just go over them. When to stop screening for mammogram is not yet established. There's some that say, if you have like a life expectancy of at least 10 years, you should keep having mammograms. I typically, if somebody's healthy and they can undergo treatment for breast cancer, then it's worth it to screen for breast cancer. And if, somebody's not healthy enough to have any sort of cancer treatment, then there's no reason to do a test if you're not able to do the treatment for it, unless you're having symptoms. So there's 3 main societies that make guidelines for breast cancer screening. One is called the U.S. Preventative Task Force. The next one's called the American Cancer Society, and then the American College of Radiology. The U.S. Preventative Task Force has the most non-intense screening. So they recommend that women actually start at 50 to 74. There's some women that can start before the age of 50, but it really should be individually based. And then that there's not a lot of evidence for women after the age of 75 to keep going with screening. The American Cancer Society gives the option of starting at 40 to 44, but really says annually for 45. And then you could consider, if you've had normal mammograms for every 2 years, to switch to every other year, and then to continue screening as long as overall health is good and life expectancy is 10 or more years. The guideline I am most aligned with is the American College of Radiology, which is to start screening mammograms at age 40. Part of this is because I see a lot of young women with breast cancer, young women, under 30 and under 40, certainly, but I also see a lot of women early in their 40s diagnosed with breast cancer, and some of them are picked up by their first mammogram. I have 2 patients in the last 2 months I can think of that their first mammogram is how they were diagnosed. The other guidelines aren't in favor of a younger age, basically because there are these like callbacks and sometimes false positive and things like that. And yes, those are anxiety producing. Yes, they cost money, but I still think it's worth it to find early stage cancers when we can. And that overdiagnosis shouldn't be a factor on when to decide to start screening or what interval to choose. And I'll just say my mom was diagnosed at age 44 by a screening mammogram. And so if we were following the other guidelines, I mean, she definitely would have died of her breast cancer. She was diagnosed with a really, locally advanced breast cancer that was only picked up by a screening mammogram. And so I'm a fan of the starting younger guidelines. This is the guidelines from the NCCN. So this is kind of like a cancer treatment, Bible that all oncology physicians go by. And if somebody is asymptomatic and their average risk for breast cancer, they say, starting at age 40 to do an annual screening mammogram, consider 3D, have breast self-awareness, get a clinical exam. Anybody with increased lifetime risk, and I'll switch to that to the next slide. And this can be by family models or by exposure to radiation, or even history of atypia on biopsy sometimes increases the risk of breast cancer. To definitely start, screening mammograms and considering tomosynthesis. Can also consider MRI screening, and then to talk about risk reduction strategies. I'm going to go to the next one. So a lot of the take-home points is, everybody's risk for breast cancer is a mixture. It's things that we can help, it's things that we can't help. Healthy diet and exercise, I think, and stress management are so important. The more fruits and vegetables you eat, the better. Cleaning produce prior to consumption, avoiding alcohol, smoking, excess sugar, a lot of starches and processed foods, hormone replacement, chemical sunscreens, plastics, BPA. Don't postpone getting screening mammograms. When we detect breast cancer early through screening, it reduces the need for advanced therapy and improves breast cancer survival. And then I just want to mention again on the screen, colonoscopy for you or anybody in your life. It's just as important as getting a mammogram. I mean, this month is all about breast cancer awareness, but I like to take advantage of the audience to just also talk about colon cancer screening. So that is it for the talk. It's 6:41, so I think we have a little bit of time for questions. If you feel comfortable talking, you are welcome to talk. Otherwise, you can ask questions in the chat. If you send them privately to me, I won't say who, I can just read the question out loud.
Thank you so much. All that information was so helpful. I love the action steps as well. So just opening it up to anyone that might have questions.
I think maybe Leah.
Leah, do you have a question?
Yes. Well, actually, I've been diagnosed with breast cancer. I went through treatment in 2018, and I'm doing really well post treatment. And I've given up sugar, and that's made a huge impact in my life on how I feel and keeping my weight down and everything. But my question is, when I go for my mammograms, I do have dense breasts, and basically I didn't have dense breasts until I got basically in my 60s, and then suddenly my breasts were dense. But I have an ongoing discussion with my oncologist. I think I should be getting an ultrasound in addition to a mammogram each time, because if my breasts are dense and I found my first cancer, I really don't want to go through it again. And so I would be really interested from the doctor's perspective, what she might think about me having an ultrasound. I mean, I realize you don't treat me, but just in general.
Yeah, that's a great question. A lot of women ask about ultrasounds. I think it's, of course, an individualized decision between you and your doctor. So I recommend following up with them. If somebody has a breast cancer that was not found on their mammogram, that makes me want to do additional testing besides a mammogram, because obviously there's like a false reassurance with the normal mammogram if it like missed the first cancer. Ultrasounds are great for that. I've had a few women that have only had cancers found by ultrasound. So of course I'm going to follow them with an ultrasound. I think it can depend on what your risk of breast cancer like coming back on. And so if they don't think that it's very high risk and it was a very favorable type and you're doing well on anti-hormone therapy and things like that, they may think that the, gain is not very high. The one downside to testing is like, sometimes we end up on we order a test, and undoubtedly in a lot of women, when they get an ultrasound, they will find probably benign things either on both sides or in the armpit. And sometimes that leads to either a biopsy or to like short-term 6-month follow-ups for a while. And so I think for some women that is a lot, and it turns out that it doesn't make a difference in the end. Like it's not like a cancer was found. And so a lot of doctors are scared to put women through that, a little bit of like a journey to be as high information seeking as possible. But a lot of times I just, tell women like, these are the pros and the cons, and then we can just make like a decision together, if they're willing to accept that, yes, we may, end up finding a bunch of things and having to chase them. But in the end, maybe if I do this, 100 times, I'll find like one breast cancer a little bit earlier. I hope that answers your question, but if there's any other questions, let me know.
Actually, it does. The interesting thing is I did have ultrasound for 2 years, thinking that I did have breast cancer, but they only tested one area of my breast. 6 months later, I found the cancer, and it was in a completely different spot.
Yes, so that's one thing about ultrasound. I'm so happy actually you brought that up, is it's completely dependent on the ultrasound technique. So a mammogram, you're really just taking a picture of a room and the radiologist is looking at it. For the ultrasound, it's like only where somebody shines a flashlight that you can even see what's there. So somebody could 100% have, something wrong at one spot. And if the tech never puts the ultrasound probe there and never saves a picture, the radiologist won't know about it. And so they won't even be able to report on it. So there's definitely some limitations with ultrasounds in terms of, their sensitivity for finding something.
Anyway, I'm doing well now, so that's what's important.
Oh, good. I'm happy that you're doing well. Thank you for sharing. For early onset period, typically 11 or younger. A lot of the risk models will classify them into different categories: 11 and under, 12 to 13, and then over 14. Mimi asked a question. And then we can take the question from Tara.
Hi, I have a mammogram scheduled for Wednesday. I'm going to say cancer survivor now because I'm in remission and have been for almost a year. So, and I haven't had a mammogram in a while because I've been on treatment infusions. So I go for a CT scan every 3 months. So I'm finally going for the mammogram on Wednesday. And my original mammogram is how they caught it to begin with, was a 3D. So my question is, because I've been hearing about this Genius exam, is that the same as the 3D, or is this Genius exam something different?
I am not 100% sure what the Genius exam is. There is a type of like computer aided software that helps the radiologist study mammograms. So it's like they basically have computer software that'll help point out abnormalities. So if a radiologist doesn't notice it, I'm assuming that that is what it is referring to. And most places use some sort of like computer automated detection now.
Yeah, I mean, now that it's, October and Breast Cancer Awareness Month, every program is touting something. And I just heard about the Genius exam and how you should ask for this exam when you go in to get your mammogram. So I didn't know if it was new technology or if it was something that already exists that is just called something else.
I'm just going to Google it. City of Hope, I have not heard us use that term, but it may just be marketing again of this. Okay, so that is a 3D mammogram. And
Okay.
it's something that's only available on some certain brands of Hologic. It's like a company just like Coke versus like.
So it's a different name for another company that does the same thing.
It
it
sounds like it's just a 3D mammogram, but that's their specific like machine.
Gotcha.
No, it does take a 2D mammogram, which most of them do too, and a 3D like on the same time.
Hmm.
And it says it's the only mammogram that is FDA approved as superior for women with dense breasts. So they must have done some studies to prove. Yeah, I've not heard that term, but yeah, it's exactly what we're talking about, 3D.
Okay. I mean, I'll just ask them if they have that. It wouldn't hurt.
Yeah, I'm on their website. I'm going to see. I'm putting within 20 miles of Pasadena. So Jim and Eleanor Breast Center have it. Arcadia Women's Center has it.
I'm going to Tarzana. Is it? Oh.
Marcia Ray has it in Glendale. USC Verdago has it. City of Hope has it. USC has it. I know this one you're talking about in Tarzana. The name is like escaping me right now too.
It is, yeah. And my doctor is with Cedars, the umbrella of Cedars Sinai. So
I think that the Tarzana one probably does have it because I think they're a RadNet facility and Arcadia's RadNet. So I'm assuming that they just have the same companies.
Okay, thank you.
Yeah, of course. Somebody asked a specific question about a PELB2 mutation. So there's a lot of different mutations that can cause, I'll try to share my screen so I can show you guys this, that can increase the risk for breast cancer. Most people have heard of BRCA1 and 2. Those are genes that protect us against getting cancer. And so if somebody has a mutation in one of those genes, it makes us higher risk to get cancer. And for BRCA1, it's a strong risk of breast and ovarian cancer. For BRCA2, it's a strong risk of breast and ovarian and also a little bit more of a risk of pancreatic, prostate, and melanoma. So PELB2 is a gene that people are learning more about, and it's actually kind of nicknamed BRCA3. So for that, there is a consideration for screening for pancreatic cancer. So for a male, if they had it, but a lot of that is driven by family history. So if no one in the family's ever had pancreatic cancer, your family's specific gene mutation may not be one that's prone to cause pancreatic cancer. So you don't need to undergo screening for it. In terms of the breast cancer screening, I wouldn't recommend anything for a male. It would primarily be like a good clinical exam. And then there'd be no ovarian cancer risk to have to worry about for a male also. Sharing.
So doctor, for lymphedema of the arm, so what do you usually advise, suggestion to reduce it?
It's a great question. Lymphedema, just so we're all on the same page, has to do with arm swelling that is permanent after somebody has treatment for breast cancer. So the body has the system of artery and veins that most of us have learned about, but it has a completely separate system called the lymphatic system that's part of our immune system. And so throughout our whole body are these like tiny little channels, and they all meet up in different areas where we have a lot of lymph nodes. And so we have lymph nodes throughout our whole body, and we have a lot underneath our armpit, and underneath the armpit drains the breast, and it also drains the arm. And the lymph nodes are the most common place that breast cancer will spread to first. And so as part of like the surgical staging for breast cancer, we routinely remove at least the first lymph nodes that drain the breast. A long time ago, they used to remove all of the lymph nodes underneath the armpit, called an axillary dissection. And then they discovered that you don't have to remove all of the lymph nodes all the time. You can actually find the first lymph nodes that drain the breast. And we find those by injecting a blue dye or a radioisotope in the breast and finding whatever is blue or radioactive in the armpit and removing those. And they found that actually you don't have to remove more. Even sometimes if there's cancer in them, you can just have people get radiation. But some women still need to get axillary dissections, and axillary dissections refer to taking out a lot of the lymph nodes in the underarm, not all of them. And certainly we are trying to take out less and less all the time. But sometimes women can get lymphedema too from just a sentinel lymph node biopsy too. And so when people get lymphedema, it's because the freeways that are exiting the arm have been completely, unfortunately, cut by the breast cancer surgery in the underarm. So if we took out, like the 210 and the 605, it's like all of the city streets start to become more congested. And sometimes it's a little bit subtle, like sometimes patients don't notice it, but we notice it, or it's just, just a little bit of swelling in their upper arm, but it can go all the way down to the fingers. So, and you can imagine, again, just if the 210 and 605 was closed, there'd be just some congestion. If something bad happened, if there was or let's just say the Olympics were like in Altadena or something, there would be like a lot more traffic on the freeway and a lot more traffic on the city streets. And so if the arm has something happen to it, like a really bad sunburn or mosquito bites, it increases the amount of lymph fluid that needs to be processed. And that can cause lymphedema to be worse. So for lymphedema, if somebody has it, one of the most important things is to take good care of the skin on your arm and avoid, basically trauma and infections to the arm. At City of Hope, we are really trying to improve the quality of life for women that have lymphedema. And we're doing that in a few ways. One, if we are anticipating that we need to do an axillary dissection, at the same time that the breast surgeon takes out the lymph nodes, we actually have a plastic surgeon find those little cut ends and sew them to a vein to decrease the risk of lymphedema. And the risk of lymphedema, if somebody has an axillary dissection and needs to have radiation, is about 30%. And there's been studies that have shown having that same procedure at the same time, the lymphovenous reconstruction, can reduce the risk to about 10%. So it's a pretty significant change. The second thing that we are doing is lymph node procedures after somebody already has lymphedema. And so there's a couple different ways that plastic surgeons are able to do that. One is by lymph node transfers, so bringing in lymph nodes from other parts of your bodies to kind of take over and resume the role of the lymph nodes that were removed. Another surgery that one of my patients has had is lymphatic bypasses. So like in the actual arm where there's been lymphatics that have gotten big over time, actually doing these tiny little surgeries just on top of the veins and the lymphatics and reconnecting them so that they have a way to drain, and that decreases the congestion. And then we just had a new plastic surgeon join us from USC named Alex Wong, and he has a lymphedema trial open where they're using a medication on women that have had lymphedema to see if it reduces the risk of breast cancer. So they're randomized to either get this medication or not. And then we will follow them and see if it makes a difference in the lymphedema.
Do you know the name of that medication, doctor?
No, but I can probably look it up for you right now. I don't even know if it actually has a name since it's part of this trial, but I'll tell you what it is. if I can find it. So it is called, I'm going to put it in the chat because it's DEUPIRFEDIDONE, and it's called LYT 100. I think it says it. I don't think it's like a known, like a medication that they've used for other, that you could like Advil or anything like that.
Okay.
Like
Thank
it's
you.
a novel agent. But we are looking for patients for this trial. If anybody suffers, unfortunately, from lymphedema and is interested in participating in a trial, it is a phase 2 trial.
Okay.
Someone asked in the message, how important is it to take tamoxifen? And I would say it is extremely important to take tamoxifen or any other, medication that's prescribed after somebody gets diagnosed with breast cancer. We've talked about a few times that when women get diagnosed with breast cancer, there's a lot of different kinds. I'm sure you guys are aware because you're involved in the cancer support community, but like some people have triple negative breast cancer, some people have HER2 positive breast cancer, but most women have estrogen-driven breast cancers. And so anytime anybody gets diagnosed with breast cancer that's invasive, so not pre-cancer, but invasive breast cancer, we have to treat the cancer in 2 ways. We have got to treat the breast, which is local therapy. That's what breast surgeons do and radiation doctors. We also have to treat the whole body, which is systemic therapy. A long time ago, like 50 years ago, they used to only treat the breast for breast cancer. So they would do very radical surgeries. They would remove the whole breast. They would remove the muscle. They would remove lots of lymph nodes. But women still died from breast cancer. And the reason that is because when women have invasive breast cancer, there are likely cells floating around their body. And this is true, and it can sound a little bit disturbing. Even when there's lymph node negative breast cancer, women can still have breast cancer cells floating around their body. So when we remove the breast or we remove part of the breast and women get radiation, that takes care of breast cancer locally, but that does not treat the body and these theoretical cells that have escaped. And so some women need to have chemotherapy to treat their breast cancer, but most women that have the estrogen-driven breast cancers only need to take a pill that reduces the risk of breast cancer coming back. And that pill starves the body of estrogen. And so the most common pill is tamoxifen, because that's the oldest one. There's a newer class of medication called aromatase inhibitors, and those are given to women after menopause. And they block an enzyme in our blood that makes estrogen. And so regardless of which pill it is, they're all reducing the risk of, it's basically reducing estrogen in our body. So if there is a cell that is hiding somewhere, so the common places are liver, lung, and bone and brain, that cell, wherever it is, basically starves to death because you're taking an anti-estrogen pill. And it's very important to take it at least for 2 years. The studies have shown if you take it for less than 2 years, it's really not providing any benefit. But for some women, it's 5 to 10 years. And even though the pills are really, really difficult, they are the best chance of preventing a distant recurrence of breast cancer coming back somewhere else in your body. A lot of women now get a special test called an oncotype, which is where a piece of your tumor is sent to a lab after you have surgery, and you get a score that tells you the chance of cancer coming back. And if any of you are wondering, like, gosh, how important is it that I take tamoxifen or some anti-estrogen therapy? You can ask your doctor if you happen to have this test. It tells you the chance of cancer coming back with that pill. And so if the number is like 9%, I typically double it. And I say, if you don't take this pill, that's a 18% chance of it coming back. Is that okay with you? And there's some women that have a really low score. I mean, it's like 2 or 5%. And honestly, for them, the pill side effects aren't just like worth their quality of life. And so they stop taking it. Have lots of patients that don't take the pills. And, I definitely try to educate them as best as they can, but, they can make an informed decision too. And if the side effects are too much and they don't want to take it, then we just carefully follow them. Most women who get breast cancer aren't going to have their breast cancer come back.
Thank you so much, Dr. Schultz Costello. I want to be aware of your time. We can't thank you enough for how interactive this was. We always appreciate a speaker who can navigate Zoom so gracefully. So thank you so much for being here with us. We will post this recording. What we're going to do is launch a poll for everyone. We want to hear your thoughts about this program and your what else you want to be seeing from us. We have a lung cancer presentation coming up on October 26th. It's going to be informative, just like this one. But also, Dr. Schultz Costello talked about the importance of nutrition, and we're going to have a breast cancer nutrition program coming up early November. I believe it's November 6th or 5th, the Friday. So please take a look at our calendar. Dr. Schultz Costello, we just thank you so much. I hope you're looking at the chat and seeing all those things come through.
Yeah, thank you so much. I would love if you could send me the link to your breast cancer nutrition talk. If I can that, I would love to hear. I think that is just so underutilized in women, and we really can look at food as like medicine, and it's just something we can change.
Fantastic. I'll absolutely send that your way. Thank you so much for your time.
Yeah, thank you guys so much. Great questions. And anytime you guys need any sort of talks, or if you want to hear more about lymphedema, I can have a plastic surgeon come, breast reconstruction, anything.
I would love that. Thank you so much.
Yeah, thank you guys. I'm going to head out. Thanks.